This short presentation is on integrative learning in basic and clinical sciences, concepts and strategies. I'm going to describe the concept of integrative cognition and an integrative approach to teaching basic and clinical sciences, and then talk about instructional strategies for achieving integration. The Edinburgh Declaration back in '88 challenged medical schools worldwide to enact some recommendations. One of those was how to integrate the teaching of clinical and basic sciences so that students would be responsive to the communities they would serve when they enter practice. When we talk about curricular integration, we're talking about both the cognitive activity in which we want students to engage and how we structure the curriculum itself. This includes how we define the basic sciences. There's been over the years an expansion to include things beyond the biomedical science. That would include behavioral sciences. There are several strategies that we've been using for many years to achieve this integration: problem-based or case-based learning, real and simulated clinical experiences, as well as co-teaching or team teaching between scientists and physicians. What really matters is cognitive integration. That is getting students to think in both realms, leveraging both basic sciences and clinical science in order to arrive at an accurate conclusion, whether it's a real or simulated medical problem. We can liken this to another kind of cognitive integration we've been talking about at the college the last few years, which is the same kind associated with Daniel Kahneman's book, Thinking Fast and Slow. That is the combination of engaging in pattern recognition and the deliberate examination of the evidence presented in a given clinical case. Teaching by analogy is nothing new, but it is effective. We often use analogies in science and medicine to explain difficult concepts, and some of you may already do this pretty routinely. But we're encouraging you to use analogies, especially when you have something that's more complex or not easily rooted to something students have already learned about medicine. And this is particularly true with first-year students, where many of them do not have any prior medical training or knowledge. So we want to be explicit and analogize. The explicit part just simply means, yeah, we're about to make some connections here between the basic and clinical sciences and demonstrate why it's so important to leverage both domains of knowledge when you approach a patient situation. And then secondly, make sure your analogy is anchored to something students already know or are highly likely to know and be real familiar with. It doesn't even have to be in medicine or in the basic sciences. It could be a lay experience. In this case, rather than starting with a subarachnoid hemorrhage imaging, we could instead talk about a leaky hose. So we can use an analogy to a lay experience to emphasize the kind of thinking we want students to engage in. We can say, sticking with our leaky hose analogy, some causes are obvious. We can see that there's some flooding, and we see on the left the hose is leaking pretty badly, and we need to stop that. Right? We need to fix it. We know exactly what to fix. Whereas on the right, we have to engage in a little bit more slower down, deliberate kind of examination of evidence because we've got a flood, but we don't know what caused it. So this is an example out there in the public sphere of Southwestern Medical Center using an analogy to do patient education for patients and families, and likening the process of a hemorrhagic stroke to filling a water balloon with a fire hose. We encourage you to use analogies to teach students how to think in an integrated fashion between the basic and clinical sciences, as well as fast and slow. Please contact me if you have any questions about this or about transforming your session using the active learning template from Curricular Affairs.